Hi, my name is Daniel Gomez, and this is a presentation for the AACR-JCA Joint Conference in Maui, Hawaii, from December 10th to December 14th. And my poster will be at A79 at the Hyatt Resort. So this is my poster is on co-infection and cancer. Viral oncogenesis in humans result in liver, blood, and brain cancer by host pathogen interactions. HIV and HTLV co-infection results in viral oncogenesis in several cancers and through specific pathways. So both viruses initially infect dendritic cells and then propagate infection to CD4 T cells through cell-to-cell transmission using mechanisms including the formation of virological synapses, viral biofilms, and conduits. So these viruses are both neurotropic and neurovirulent, have neurovirulent determinants. So there are specific neurodegenerative diseases that are caused by these specific viruses, retroviruses, but we will only be discussing the co-infection and cancer or the oncological aspect. So current vaccines and therapeutics of HIV and HTLV have been assessed through this review in this paper. But specific to ATL or adult T-cell leukemia, lymphoma, and HIV-associated cancers, there still remains to be much work done here as far as therapeutics and vaccines and therapy. So the associations with the cancer malignancies and HIV-1 and HTLV-1 are also associated with other oncogenic viruses such as EBV, HBV, HCV, HDV, and HPV. So we'll start with the HIV-1 and HTLV co-infection. So the infection can occur through several transmission pathways, either cis or trans. But essentially it's in the blood with PBMCs. You can see in the first figure the virus in the blood with red blood cells. You see the HTLV one virus and an activated T cell, a dendritic cell, and the HIV-1 virion, as well as red blood cells. So we can find that if we take the blood from these specific patient populations. So it goes through the blood circulation as well as the lymphatics, and then reaches the spine as well as the brain. So there's an excessive production of defective lymphocytes that cater to the environment of these high level of HIV-1 virions that are produced. So this can, the HTLV-1 virions can actually upregulate the HIV-1 virions and the HIV-1 infection by activating the CD4 positive T cells. So in the PBMC culture in itself, both viruses can activate each other. So there's some synergism that happens there. Specifically, the TAX protein of HTLV-1 stimulates the HIV-1 replication by activating the HIV-1 long terminal repeat region, or LTR. And in cancer in HIV, you see a co-infection of HIV and hepatitis B and C. So this actually increases the liver-related morbidity and mortality, including HCC or hepatocellular carcinoma. So how do we go from liver cirrhosis from either HPV or HCV infection to hepatocellular carcinoma, HCC? Well, there's inflammation, fibrosis, and cirrhosis that happens, and these are due to inflammatory cytokines. The inflammatory cytokines are produced by the virion virulence factors such as TAT and GP120 for HIV. For HBV, you have HBX, and then for HCV, it could be the core E2 or several other proteins that actually bind to TLRs 1 through 10, or for HIV, TLRs 4 and 9. And these will induce a reactive oxygen species stress response, where you can see the cancers actually be transformed. So there's an overexpression of the viral oncoproteins that induce the oxidative stress, and then the chromosomal instability and genomic damage, which produce the chronic inflammation, leading to liver damage and malignancy. In the blood, adult T-cell leukemia or lymphoma, ATLL, HIV-1 infection induces ATL in about 2.5 to 5% of cases. So ATL is an aggressive malignancy with a short survival rate that develops more commonly in children infected with HTLV-1 compared to infected adults. The most common symptoms of chronic ATL include the skin rash or swollen lymph nodes, as well as lymphocytosis. And then the presence of specific subtypes from a slow progressing to a highly aggressive one are ERV4 or MUM1 gene mutations. In HTLV1, the causative agent, the proteins TAX and HBZ are two key proteins that are involved in the oncogenesis. So you can see in the figure here that HTLV1 and HIV1 bind to DC sign, and GP120 bind to DC sign, and GP46 bind to DC sign, and then there's a signal transduction pathway that occurs from RAS, RAF, MEK, ERK, and importin that gets sent through the nuclear pore complex, where ERK can bind to transcription factors that are phosphorylated and then induce migration, invasion, and angiogenesis. And then another pathway would be which is involved with TAX, with HTLV1 TAX. You can have TLRs that induce NEMO, as well as I-kappa Bs and NF-kappa B pathway, which will result in oncogenesis, proliferation, and survival. So overall, ATL is an aggressive T-cell malignancy caused by HTLV1 or human T-cell leukemia virus, type 1. So if you look at the tissue of the blood and look at the lymphocytes, the ATL is characterized by abnormal lymphocytes, and these are called flower cells. So they are known to be cleaved and they have convoluted nuclei. So we can see their T-cell markers, the HTLV1 antibodies in serum, as well as monoclonal integration of HTLV1 provirus in the affected cells. So the presence of the flower cells and the low presence of antibody to TAX regulatory protein are all characteristics, or protein of the HTLV1 are all characteristics of ATL. In the viral oncogenesis, you have NF-kappa B, which I mentioned, as well as EBV LMP1, which could be a growth factor proto-oncogene that activates TRAF, and then the TLRs or TNFRs, TCRs, BCRs, or RANK, or CD30 or CD40 can actually induce IRAK1 or TAC1 to send a signal to IKK, and then I-kappa B, as well as NF-kappa B. And once NF-kappa B is expressed, HTLV1 TAX protein activates that NF-kappa B to be translocated into the nucleus and then transcribed from there. So that's one viral oncogenic pathway, as well as Notch. And in Notch, you have the Notch receptor, ADAM10 and gamma secretase that are involved with the cleavage of an intracellular Notch domain, where HBV, the HBX protein that I mentioned, can actually cleave that intracellular Notch domain, and then that gets sent either to the proteasome if it's polyubiquitinated, or it's sent into the nucleus and then facilitates transcription as well. So HPVE6 can actually inhibit the MAML1 or mastermind like protein, as well as CSL. But this is showing that viral infection is a major contributor and a global cancer burden. So oncogenic viruses promote tumorigenesis via shared host cell targets and pathways. And above are those molecular mechanisms of viral oncogenesis in humans. And there are also viral manipulation of host cellular signaling, DNA damage, responses, immunity, and microRNA targets that promote the initiation and the development of cancer. In HTLV EBV co-infection, we have HTLV1 that induces T cell dysfunction and B cell proliferation. So EBV is known to infect B cells and epithelial cells, and in EBV positive diffuse large B cell lymphoma, or EBV DLBCL, or not otherwise specified, NOS, is a classification of a lymphoid neoplasm and an aggressive B cell lymphoma associated with chronic EBV infection and a poor prognosis with standard chemotherapeutic applications or approaches. And the combination of HTLV1 co-infection and the immune senescence may be transmitted by saliva, and especially in people living with HIV. So HTLV1 can potentially activate an EBV promoter. So EBV DNA, proviral DNA for HTLV1 and the TAX mRNA has been detected in 2 B cell lines, Raji for EBV and then Jurkit for HTLV1 from peripheral blood of ATL patients. EBV and HTLV1 double transfectants displayed an enhanced expression of cell adhesion molecules and high levels of interleukin-4. So EBV infection is often observed in the clinical course of ATL. And the oncogenic infection of HTLV1 and EBV triggers an EZH1/2 perturbation and a histone 3 lysine 27 trimethylated deposition. So histone 3 lysine 27 trimethylation reprogramming is a hallmark of cancer. And oncogenic and these structures of EZH1 and 2 dual inhibitors have been shown in the literature. So these are called ORS1 or ORS2 as well as DS3201 or valometostat. And these effectively diminish histone 3 lysine 27 trimethylated and induce gene reactivation. And this shows that ATL-related immunodeficiency might induce EBV-associated DLBCL and associated infection complications. In the co-infection of HIV and EBV, we show that most HIV-1 positive individuals also harbor EBV and HIV, that actually augments the EBV-associated malignancies that are increased with people living with HIV. So EBV-related B-cell lymphomas occur frequently in AIDS patients. And the infection is associated with primary central nervous system lymphoma, or PCNSL, which occurs at a high rate in immunocompromised individuals. And this validates that the immune system plays a critical role in inhibiting EBV activities. So primarily, EBV latently infects the B cells and the nasopharyngeal epithelial cells and could interact with follicular dendritic cells in the germinal center. So these can be transmitted by saliva, semen, or vaginal secretions, and more frequent detection of EBV detection in saliva has been shown in an HIV-1 co-infected person. So this is a major cause of cancer in people living with HIV. So some of the mechanisms of transactivation of HIV LTR construct is shown by an EBV product. So the EBV protein does transactivate the HIV TLR, and then it appears to transactivate its own promoter BMLF1 by post-transcriptional mechanisms. So EBV can also infect the neurons directly or indirectly through B-cell mediated neuroinflammation and demyelination. So it remains to be seen if EBV proteins like or biomarkers like CD20, CD30, and EBER or EBER interact with HIV proteins like GP120, NEF, P17, TAT, or reverse transcriptase. But this shows that brain cancer is highly prevalent in people living with HIV, and the mechanisms of CNS malignancy are shown here. So this is the blood-brain barrier, and you can see the red blood cells as well as T cells, and T cells do carry virus into the brain through a Trojan horse mechanism. And then dendritic cells also move through the blood-brain barrier, and you can see them inside the brain with activating T cells inside the brain. So the virus gets across through the T cells. That dendritic cells also prime antigen to T cells inside the brain. You can also see pyramidal neurons as well as microglia. And then at the blood-brain barrier, you see endothelial cells and parasites, as well as the astrocytic infeed. So once the virus is in the astrocyte, it serves as a reservoir. And you can see the HIV virions shown here in this cartoon inside the astrocyte. So this makes a reactive HIV-infected astrocyte. And then as well as the astrocytes, we can also have HIV-infected cortical neurons. So we have here a cortical neuron with HIV virulence factors such as TAT or GP120 inside a cortical pyramidal neuron with dendritic spines. So kind of zooming out, you can see the a slice of the brain and see the brain tumor on the cortex. So this is a brain tumor and immune cells where you can see the tumor immune microenvironment in the brain and the tumor virology there. Once the tumor is established as a primary tumor, it can then metastasize from the BBB to other locations in the body. There's a current study, or a study that I've read and presented on, that showed secondary metastases of a brain tumor into the anterior neck, as well as a T9 in the spine. And this was in a younger patient. As far as glioblastoma multiforme, GBM, those can occur nearly 3 years after HIV-1 infection. So HIV-1 infects several brain cell types, such as astrocytes, which serve as those potential reservoirs for productive infection, viral persistence, and latency. And the astrocyte elevated gene 1, or AEG1, is implicated in this malignant glioma progression and invasion. So AEG1 enhances proliferation, angiogenesis, and chemoresistance and metastases of this malignant class. So these are the hallmarks of malignant gliomas. You have tumor proliferation, invasion, angiogenesis, metastases, and chemoresistance. So these glioma cells can link up with HIV-1 envelope protein, GP120, to increase glycolysis and the Warburg effect. So both TAT and GP120 induce the epithelial mesenchymal transition, or the EMT, and the cell migration via the TGF-beta and MAPK signaling pathways. The accessory protein negative factor NEF inhibits the apoptotic function of p53, which affects its half-life and the DNA binding activity and transcriptional activation. So HIV-associated carcinogenesis can be driven by persistent immune inflammation, dysfunction of B cells, and T cells. So the components of the cells in the innate immune system, as well as potentially dendritic cells. In PCNSL, it's the second most common neoplasm in HIV-1 infected individuals, and the first intracranial tumor, representing 20% of all lymphomas in patients with AIDS. So PCNSL is 3,600-fold greater in AIDS patients than the general populations. So PCNSL in patients living with HIV is a distinct entity, and it's considered an AIDS-defining condition. The prognosis of HIV-related PCNSL is poor, with the median survival of varying between 2 to 4 months. But patients with chemotherapy typically do better, and they could survive a median of 1.5 years. I show here the histopathological features of primary CNS lymphomas, where you can see the MRI of the brain in the case of PCNSL that reveals a large necrotic mass involving the right basal ganglia and producing significant brain edema. The brain also demonstrates a large infiltrating mass that affects the basal ganglia, including the caudate nucleus and the putamen, as well as the globus pallidus. The tumor is friable, granular, and exhibits an area of necrosis and focal hemorrhage. So you can see some of the histopathology here at 400 and 1000x with specific biomarkers of EBV and JCV, large T antigen. So CD20 is shown, EBV LMP is shown, and JCV TAG is shown as well. And you can see them overlaid in the co-localization there as well. So EBV and JCV are both co-infections that involve expression of viral proteins, LMP, and T antigen, which can bind, sequester, and inactivate tumor suppressors, p53 and PRB, leading to the dysregulation of cell cycle and uncontrolled proliferation. Our conclusions are that the viral-induced oncogenesis contributes to a significant proportion of cancer cases, and can be caused by viruses in several different families. Viruses promote the development of a variety of cancers, such as Burkitt's lymphoma, Hodgkin's lymphoma, T-cell lymphoma, nasopharyngeal carcinoma, gastric carcinoma, Kaposki's sarcoma, hepatocellular carcinoma, cervical adenoma, glioblastoma or astrocytoma, and primary central nervous system lymphoma, as well as a subtype, which is the diffuse large B-cell lymphoma. Among the oncogenic viruses, dendritic cells are important to intercept the virus early in infection. Some future directions are to look at the dendritic cells that provide promising focus for research in retroviral infection and other oncogenic viruses. We could also target the AEG1 to slow down the progression and invasion of gliomas against infectious diseases and cancer. So we can, or invasion of gliomas. So AEG could slow down the progression. If we target AEG, it could slow down the progression and invasion of gliomas. We can also use structural vaccinology to design epitope-based vaccines against infectious diseases and cancer. There's also engineering immunotherapy to target viral oncology pathways by molecular circuit reprogramming, such as CAR transduction or the SYN-Notch CAR T circuits, as well as considering avoiding immunotherapy resistance. There's also the possibility of priming CNS-specific antigen myelin oligodendrocyte glycoprotein, or MOG or MOG, to enable tumor cell killing by targeting antigens that are homogeneous. This overcomes the specificity, the heterogeny, and the persistence in glioblastoma. And lastly, we could target the retroviral endosomes of HTLV1 and HIV1 with allosteric inhibitors or alines of that occur during particle assembly, which happens during replication. I want to thank you for your time. This is my poster for AACR and JCA Joint Conference, the 12th Annual Conference, and I look forward to seeing you there.